from the University of Florence, accelerated partial breast or whole breast irradiation after breast conservation surgery for patients with early breast cancer. 10-year follow-up results of the APBI IMRT Florence randomized phase 3 trial.
Thank you very much. Thank you. It's a big opportunity to me today, be here. So I have now several conflict of interest statements to declare. As we well know, recent development in radiation oncology for breast cancer show a fast move towards a de-escalation strategy for breast cancer in early breast cancer, including accelerated and not partial breast irradiation. And what we have learned from major phase 3 trials, and the last years where we presented the RAPID trial and an NSABP 39 RTOG 0413 trial just published last week on The Lancet, and that if the disease control is closely related to the inadequate selection of patients for partial breast irradiation, the safety profile and the cosmetic outcome is more strongly associated to the technique concerns, technical choices. So the approach, the dose, the number of fractions per day, and the total dose. So the accelerated partial breast irradiation trial, Florence APBI IMRT trial, is a phase 3 trial, a single center that enrolled between 2003 and 2013 520 patients that received breast conserving surgery, PT less than 25 millimeters, final surgical margins more than 5 millimeters in patients aged more than 40 years old, that were randomized 1-to-1 to receive accelerated partial breast irradiation using an IMRT technique, 30 gray in 5 fractions, non-consecutive is a schedule any other day, as compared to conventionally fractionated whole breast irradiation, 50 gray in 25 fractions, and a tumor bed boost of 10 gray in 5 fractions. The primary endpoint of the study was the ipsilateral breast tumor recurrence, and the 5 years results were presented here in San Antonio in 2014. At the time of this analysis, the median follow-up of both arms are more than 10 years, and every patient in every single arm receive a follow-up of at least 7 years. This is something about target delineations and quality assurance on our technique. It's a very easy technique. We need at least 4 mandatory surgical clips to identify the target, and the CTV was obtained by an isotropic 1 centimeter expansion, and the BTV it is obtained by another isotropic 1 centimeter expansion, limiting 3 millimeters by the skin and up to 4 millimeters intrusion toward the lung. These are the organs at risk that we contour, very simple: contralateral, nomolateral lung, homolateral breast, contralateral breast, and heart, using these constraints. Coming to the results, to note the patient characteristics that will be presented this afternoon, most of patients were aged more than 50, more than 90%, T1 tumor, negative nodal status, ER positive, and margins more than 5 millimeters. This is the primary endpoint. At median follow-up of 10 years, the 10-year cumulative incidence was 3.9 in the APBI arm as compared to 2.6 in the whole breast irradiation arm. Very low rate of events, 9 events at the 10-year in the APBI arm as compared to 6 events. That's the ratio is 1.57, p-value at 0.39. And just to show you the other local control outcomes, there is no difference, just 9 events as compared to 7 events in the local regional recurrence rate, so 3.9% as compared to 3%. And concerning contralateral breast cancer, to note, we observed just 2 events in the APBI arm as compared to 8 events in the WBI arm. It's less than 1% rate at 10-year cumulative incidence at 10-year for the APBI arm as compared to 3.5% in the WBI arm. Again, not significant. Concerning survival outcome, we had just 7 events each arm concerning distant metastasis, so the rate each arm was 3.1%, non-significant. As you can observe in the slides, there's a complete overlap also concerning breast cancer-specific survival and overall survival, where we observe for the breast cancer-specific survival at least 97.5% each arm as a ratio of 0.87, not significant, and the overall survival is basically completely overlap. Coming to the analysis of the adverse events, this is our results in terms of the acute toxicity as assessed by the RTOG and the RTC acute toxicity scale. As you can observe, we have very good results in both arms, but significantly in favor of the APBI arm. Even if you consider any grade of toxicity incidence, any single grade and grade equal or greater than 2. Late events, again, we observe very nice results, but in general terms, always significantly in favor of the APBI arm. If you consider any grade, if you consider any single grade, no grade greater than more than 3, or grade equal or more than 2. And finally, Cosmesis. This is a crucial point since other trials have some concerns in terms of schedule adopted. We observe very nice results each arms. We use the Harvard Breast Cosmesis scale, so is a Cosmesis scale that evaluates just the effect of radiation therapy on Cosmesis. So very excellent, good results. But again, this is the physician rate Cosmesis outcome, again in favor of the APBI arm. Concerning the patient rated, that's a difference, a clear difference, since patients are more self-critical, but again, we have more than 90% of good, excellent results, but again in favor of the PBI arm. Please note a 15% rate of favor results in the whole breast irradiation arm. So, coming briefly to conclusion, our 10-year cumulative ipsilateral breast tumor recurrence incidence rate in this early breast cancer patient treated with an external accelerated partial breast approach using an intensity modulated radiotherapy. This is a 5 once daily fractions in a schedule any other day, 30 grain, 5 fractions, is low, and basically not significantly different from patients treated with conventionally fractionated whole breast irradiation. We also observe comparable results in terms of local regional relapse, distant metastasis, breast cancer specific, and overall survival rates. Acute and late adverse events and cosmetic outcomes as assessed by patients and physicians were also in favor of the PBI arm. So basically this is just another piece of the puzzle, but we could consider that the PBI might be a standard alternative to WBI arm in very low risk early breast cancer patients. Thank you.
Thank you. This presentation is open for questions. One question I have, your eligibility criteria were pretty strict with fairly wide margins of 5 millimeters.
Yes.
How many, do you have any idea how many patients didn't qualify because they had 2 millimeters, and 2 millimeters is, in most standards, standard of care?
Yes.
Did the surgeons have to go back and take more, or did you, how many? Thank
you for the question. Since nowadays, in our clinical practice, we use the 2 millimeters exactly using the Astro and Astro recommendations. So in our routine practice, we use the 2 or equal to millimeters margins. At that time, when I tried design, it was the most adopted thresholds. So it was not the discussion about the clear margins or not. So now it's changing. We routinely use this schedule in our institution.
So you're now, with this schedule of short-term radiation, you accept patients with 2 millimeter margins?
Yes.
Hi, so can you, maybe I missed it, but can you explain what the patients go through, you know, to have both forms of radiations, like how much easier it is on the patient, how many visits, that sort of thing?
No, the same visit of all the first treatment and last treatment visit. Yeah, we have no adverse events during treatment during this schedule adopted. Yeah.
This is 5 days.
It's 5 days.
Conventional is 25 days.
Well, that's what I was.
Any other day. So it's Monday, Wednesday, Friday, Monday, Wednesday. So we visit the first time, the last time, or except patients ask for visit, obviously. But really, in acute, we have basically 0% of acute events during this treatment.
Okay, and so conventionally, it's, Dr. Osborne, you said 25.
Yes, okay. But at that time, because that trial was designed what was the standard, for example, now we use the 40 gray in 50, in 15 as the upper fractionated schedule.
Other questions?
Sorry, pardon me if this has been addressed. Marilyn Marchione from the AP. Last year, I think it was, we had a very large randomized trial that kind of suggested different results from this, and I'm just wondering how
I
to
think
square
you're
them.
referring to the rapid trial, no?
It's Frank Meattini's.
Yes.
That-
Yeah, the rapid trial is the only one trial that has some concerns about toxicity. It was very well studied. There's a very nice editorial by Soren Benson that strictly evaluates this concern. This probably was related by the total healthy breast volume irradiated, first of all. That is completely different the threshold that we use in our organs at risk threshold study. And to note the recovery time between patients, between fractions, because it was a twice daily. The IRMA trial, for example, that was not fully published, but it was presented at 3-year cosmetic results during the last European Estro Congress, show no significant problem in terms of adverse events. And it is a twice daily schedule.
So are you saying that the results are not in conflict with that? And is there anyone else that can comment on that?
Sorry, I don't understand.
You're saying the results of your study are not in contradiction to the other one, and if anyone else can help us
Not in
understand?
contradiction, because this is a once daily schedule. It's in line with all the once daily schedule partial breast irradiation study presented. So as, for example, even if it's not an accelerated partial breast trial, the import low trial, for example, that's not affected at all. And so on. This is the only one phase 3 trial with some concerns in terms of cosmetics results, the rapid trial.
Yeah, they were different techniques, so it's hard to compare. This technique might be better than that technique. There's a webcast question.
Yes, hi. This question is from Elizabeth Cairns with Vantage. This is for Dr. Johnny. Why do you think atezolizumab missed on PCR when Pembro hit on the same measure in the Keynote 522 trial in a similar setting?
Well, there are several points. It is not true they are different trials and not only different drugs. They are different because of the type of chemotherapy that is the backbone to the immunotherapy, and also the overall type of duration of the treatment is different. This may affect the results in terms of pathological complete response. And, you know, the results that we present, other point is that the pembrolizumab study was designed with PCR as an endpoint in mind, and this is in part and this explains the difference in numbers. We have a relatively smaller study where there is only a timid trend towards an improvement of pathological complete response, but it's just a very preliminary type of analysis. So if the question was how comes that atezolizumab doesn't work, is way too early to conclude that it doesn't work. It doesn't improve significantly the rate of PCR. It may well have a long-term influence.
Thank you. And one more. This question is for Dr. Schmid.